We are live, please.
So, good evening and welcome to all the chairpersons and moderators and all the attendees of this webinar. This is the next in our series of Wednesday webinars which we are conducting uh, with the Vidarbha Ophthalmic Society in association with consecutive different district ophthalmic societies of Vidarbha. And this particular webinar today is in collaboration with the Chandrapur Ophthalmic Society, and this is the first in the new season under the leadership of our President, Dr. Sean Chinchole, and Honorary Secretary, Dr. Subodh Purohit, sir. We will be having today our national speakers, Dr. Manoj Saswade, sir, who is the Chairman and Medical Director at Saswade Netra Rugnale and Laser Center at Aurangabad, and he is a very senior and renowned vitreoretinal surgeon. Dr. Manish Bapa is another senior retina surgeon from Nashik, who will be joining shortly for this webinar. Before we proceed, I request our President, Dr. Sean Chinchole, to give his opening remarks to start the session. Sir, please unmute yourself.
Sir is muted. Show.
Yes. Hello. Good evening, respected senior, dear colleagues and my friends. It gives me immense pleasure to welcome you all to this academic webinar jointly organized by Vidarbha Ophthalmic Society and in association with Chandrapur Ophthalmic Surgeon Society. So this is our new and first session after our installation of VOS new body team 26-27. So I welcome to all dear faculties. I extend a very warm welcome to our respected national faculties and members. First is our Guru, Dr. Manoj Saswade, sir. Sir, welcome to.
Thank you.
Yes, and you are always my Guru because whenever I heard about Retina, so it starts from Dr. Young, that is Manoj Saswade, sir.
Thank you.
So
Thank you, sir.
welcome, sir, and dear friend and mentor and a very good friend from Nasik, Dr. Manish Bape. He has not yet joined. And another one more dear and near friend who is always guided me. And he is the only one who gave me hands-on training for anti-VGF. That is my friend, Dr. Rajesh Shukle. From Chandrapur Ophthalmic Society and accomplished VR surgeon, Dr. Bhushan Upanchiliwar, sir. He is also there. Also, warmly welcome to all respected chairperson, respected Dr. Pangarkar, sir is there. Dr. Deepak Nilawar, sir, our co-chairman, Dr. Banaik, sir, welcome, sir, and esteemed panelists, Shamik Ambedkar and Himanshu. Our moderator, Dr. Sandeep Anjankar, Dr. Shubham Malpani, and our own VOS faculty, a reputed vitreoretinal surgeon from our Buldana Ophthalmic Society. Rahul, he has not yet joined, along with Dr. Vidima, Prashant, and Dr. Ayush. I heartfelt welcome to all our speakers, panelists, and participants. One more thing I always used to say, why it is Retina for all. But for before few years, before Saswade sir come to in our mind, it was Retina phobia for all. So for many of us, that phobia still is there. But after this session, definitely we can go ahead with our advancement and proper guidance. It has become an esteemed and appropriate specialty because whenever the ST courses are there, Dr. Manoj Saswade is always there to help us and how to give all the new generations anti-VGF. So thank you one and all. So please join and enjoy this academic feast. Thank you very much.
I request Dr. Sandeep Mungantiwar, sir, to address the webinar.
Good evening, respected seniors and colleagues. On behalf of the Chandrapur Ophthalmic Society, I warmly welcome everyone to today's webinar organized by the Vidarbha Ophthalmic Society. Today's topic is highly relevant to our daily practice, and I'm sure the session will be academically enriching for all of us. We are proud that an ophthalmologist from Chandrapur is delivering one of the talks. I congratulate the organizers and wish the webinar a great success. Thank you.
Okay. So, without wasting the further time, I hand over to our today's moderators, Dr. Sandeep Anjankar and Dr. Shubham Malpani, to start the scientific deliberation. Dr. Sandeep?
Yes, sir. Let's start with our first session. Can we get a first speaker online?
Yeah.
Yeah. Hi, sir. Hi, Bhushan, sir. Let's start with our first case.
Today.
Hi.
Please show my slides.
Yeah. Can someone?
Dr. Bhushan will be talking is the first talk today.
Motion
Is it talking about the cataract management in the diabetic retinopathy?
management. Yes.
He is practicing retina surgeon at Chandrapur. Dr. Bhushan, please upload your slides.
Yeah, I have already uploaded.
Share it.
Can you share your slide? Just
Yeah, please share your slide.
yes, sir.
Visible?
Yes, sir. It's visible right now.
So, good evening, everyone. Thank you, Vidarbha Ophthalmic Society and Chandrapur Ophthalmic Society for giving me the opportunity. So, I will be discussing. So, is my slide completely visible or there is some ad going on?
Yes, it's visible, very much visible. Go ahead.
Completely. Fine. So,
Yes.
today's my topic is managing cataract in diabetic retinopathy. So my objectives are to study the pathophysiology of diabetic macular edema and post-cataract macular edema, managing cataract with diabetic macular edema, and managing cataract with diabetic retinopathy. According to Winconson epidemiology study, the
Bhushan,
type of
sorry
yeah
to interrupt. There is some Microsoft OneDrive page is there
yeah.
from
That's
side.
what
So
I was
can,
asking. One
yes, can you just? If not, it's okay. You can
it's
just.
one yeah. It's okay now.
This
Yeah,
is
now
better.
it's okay. This is better.
According to the Winconsin epidemiological study of diabetic retinopathy, it was found that 20% of the patients with type 1 diabetes and 25% of patients with type 2 diabetes will develop DME after 10 years of follow-up. And diabetic macular edema is the most common cause of vision loss in diabetic retinopathy. Diabetic patients are 2 to 5 times more prone for developing onset of cataract, and the prevalence of diabetic macular edema and post-cataract macular edema in patients with diabetic retinopathy is 2.7% to 11% and 4 to 7% respectively. Let's see how the cataract is formed in diabetic patients. The hyperglycemia glucose is converted to sorbitol. The sorbitol, on greater accumulation, it causes osmotic stress on the lens fibers of the cataract lens fibers. So that causes swelling and uh, causes cataract. The other way is the osmotic stress developed by the sorbitol. It uh, gives stress to the endoplasmic reticulum and forms generation of free radicals. And the endoplasmic reticular stress also helps in release of reactive oxygenous species, which leads to free radical generation and the formation of cataract. The hyperosmolarity caused by sorbitol leads to influx of fluid and swelling of the lens fiber, which leads to the cataract generation. And it also causes apoptosis of the lens fibers, which causes cataract formation. Diabetic macular edema is an edema on clinical examination within the 500 meter of the center of the macula, or the edema greater than one disc area and within one disc area of the center of macula. On OCT, it is the retinal thickness greater than 250 micrometer. Hyperglycemia causes changes in blood flow and a breakdown in blood retinal barrier. We see capillary closure, microvascular remodeling, retinal ischemia, and alterations in the vitreous jelly. So all this, when there is ischemia and a microvascular occlusion, there is a blood retinal barrier breakage. And also, ischemia causes release of vasoactive factors like ICAM, BCAM, and inflammatory factors like interleukin 9, interleukin 8, and interleukin 6. So, this causes the breakdown of the tight junction of the inner blood retinal barrier that causes leakage and hyperpermeability and the formation of diabetic macular edema. According to the disease severity scale for diabetic retinopathy and diabetic macular edema, we classify as mild, moderate, and severe. the mild DME, there is a retinal thickening away from the center of the macula. In moderate DME, this hard exudates and thickening away from the center of the macula. And there is severe DME, which involves the center of macula with hard exudates and retinal thickening. We need to differentiate diabetic macular edema and post-cataract macular edema because the the pathophysiology is different and the treatment is different. And most of us actually confuse between diabetic macular edema and post-cataract macular edema. So diabetic macular edema, if you see on fundus examination, there is formation of microaneurysms, hard exudates, retinal thickening. While such things are not seen in post-cataract macular edema clinically and most of the time, but there can be, uh, but obviously there can be mixed feature also. But on OCT, if you see on diabetic macular edema, there is a higher outer nuclear layer to inner nuclear layer thickness ratio, and there is microaneurysms, hard exudates, and absence of retinal fluid. While in post-cataract macular edema, there is higher central retinal thickness to retinal volume ratio, thicker foveal outer nuclear layer, and you can see there is absence of epiretinal membrane, and internuclear cyst you can see mostly in the post-cataract macular edema. There are few I'm not describing all the biomarkers, just few. If you see, it's a disorganized retina inner layer. This is a picture of subfoveal hard exudates, and this is a picture of octa angiography, which shows large episode. This is important because before the cataract surgery, if you do the OCT, FFA, or angiography, we can prognosticate the patient about the outcome of the cataract. Hence, it is very much necessary, and the patient can be very well educated. He can be educated before the cataract surgery that the vision may not be completely, it will be suboptimal. The patient can be explained about it. So before cataract surgery, few investigations we have to do: HbA1c, lipid profile, hypertension, because these are the risk factors which are developing for the macular edema. We have to do fundus examination, fundus evaluation before the cataract surgery, which is utmost important because we have to categorize them as mild, moderate, and severe, and uh, you have to we have to categorize the patient as mild, moderate, severe, and PDF. And also the categorization of diabetic macular edema can also be done. OCT is required for the baseline macular edema examination, and also after the cataract surgery, the thickening can be measured. Also, it is helpful in the prognostication of the macular edema. FFA is also for diagnosing and prognostication of the macular edema status. So, what are the precautions we have to take before undergoing the cataract surgery? Free of antibiotics and topical NSAIDs are utmost important in the cases of cataract with in diabetic patients. And during the surgery, we should avoid breach in the corneal epithelium, as there is a breach, there is a delayed healing of the wound healing, because in diabetic patient there is keratoepitheliosis. We should always look for a large rexis because uh, 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 we should do a large rexis because in future the patient may require the retina laser or surgery. So that is utmost important because that can help us in treating the patient in a long run. Also, do a rexis large enough, but not enough so that there is anti-magnetization of the IOL. And this also keeps away the PCO away. And always prefer to do phaco surgery because phaco surgery will give a small incision and minimal manipulation, and also avoid a longer time of surgery. We should avoid the complications of posterior rupture, collapse of the vitreous, and positioning of the intraocular lens, or always avoid lens matter in the AC because that can lead to higher inflammation, of course, and of course, prolonged operation time should be avoided. Few prophylaxis and treatment should be considered while when we treat a patient with diabetic macular edema. Topical NSAIDs are are good, effective, and better controlled macular edema. So they have good penetration. It can be given 2 weeks before the surgery, and they have shown a good promising result in reducing the macular edema. They act by decreasing the by suppressing the cyclooxygenase pathway that reduces the prostaglandin and reduce the hyperpermeability. And topical corticosteroids are less effective than corticosteroid than NSAIDs because of the lower penetration of the drug. But they can be given as an adjunct. Hello.
Maybe we can go to the final slides because the time is up. I'm really sorry to interrupt.
Okay, fine. So let's take some scenarios while managing diabetic retinopathy. If we have a mild NPDR and moderate NPDR with cataract surgery, we can go directly with the cataract surgery and monitor uh, uh, monitor the progression of the diabetic retinopathy. If required, we can go ahead with other treatment in future. Cataract surgery with severe NPDR, better to do the laser as the diabetic retinopathy progresses with cataract surgery. So better do the laser and then go ahead with cataract surgery. In cases of cataract with PDR, ideally do the laser first, just stabilize the retina, and then go ahead with cataract surgery. If there is higher, if you go ahead with cataract surgery directly, then that can lead to rubiosis iridis, and that can be a dreadful complication. Cataract surgery with VH and cataract surgery with fractional retinal detachment, I ideally go ahead with a combined surgery. If you have a dense cataract with heavy fundus fluid, ideally go with cataract surgery and then fundus examination, and that can be treated accordingly. In cases of diabetic macular edema, mild diabetic macular edema with cataract and moderate cataract, moderate DME with cataract, you can go away with starting NSAIDs or give subconjunctival tricot and then monitor the IOP and do fundus examination accordingly and see the OCT, do the OCT monitoring so that it can be treated further in coming days so that if diabetic macular edema progresses, we can give anti-VEGF to it. In case of severe DME, ideally treat it before the cataract surgery so that because if it is done, uh, if the cataract surgery is done, the patient won't be happy because of the suboptimal vision. So it's better
Sir,
to
can you
treat
just brush up?
Yeah, it's the last slide.
Yeah.
So one more study which is most important is CCRS pre-med study. In this study, it's a randomized control trial and a landmark study. The study proposes that the subconjunctival tricot 40 milligram given to the patient in all diabetic patients before the cataract surgery, it was found that there was a reduction in the macular edema at 3 months post-op. So it advocates giving tricot injections subconjunctivally so that in all diabetic patients, so that you don't get macular edema in all of it. And also, it studied the role of anti-VEGF injection preventing macular edema, but they didn't get any statistical benefit. So my take-home message is, topical NSAIDs plays a better role in the prophylaxis, avoid complication and excessive manipulation during cataract surgery. Early cataract surgery is the key in diabetic patient, and steroids are better recommended in refractory DME cases. Anti-VEGF is the first line of treatment in DME with cataract surgery. Thank you. With this, I conclude.
Thank you so much, sir, for your kind presentation. It was a very nice talk and very elaborative, explaining each and every point, which is really important for the new surgeons and as well as every retina surgeon as well. So thank you. I think we will go to another slides, another talk, and we'll take your questions last. So whoever want to take questions or ask question can, the chat box is open. We can just have a chat discussion. And at last, we'll get around 10-15 minutes for the full discussion. So we'll discuss all those points with every consultant available with us. Can we go to another, sir, Manish, sir, for another talk?
Sandeep, I'll just take a moment from here. We
Yes, sir.
have Dr. Manish Papai sir joined with us. He is our next national speaker for today's evening. And he's
Okay.
also a prolific vitreoretinal surgeon from Nashik. He did his fellowship from the Shankar Netralaya, and he's a very prolific name in the field of vitreoretinal surgery. And we are very fortunate to have him with us today. And he's also our next speaker. So I request Manish sir to please share his presentation. We'll be talking on the relevant topic, very relevant for the today's day-to-day cataract practice and even the diabetic retinopathy practice, the relevance of FFA in the era of OCT. So over to you, Manish sir.
May I thank you, Dr. Rahul and Dr. Sandeep Pani and whole Vidarbha Ophthalmological Society for inviting me for this webinar. May I request previous speaker to please stop sharing their his presentation so I can start with my.
Bhushan, please stop sharing your presentation.
I hope Manish had a good sleep yesterday.
Yes, yes.
Because
I,
you
2:30.
you
Yeah,
were
he
live
was
at 2:30.
2:30. Yes.
So
yeah, it
let's
has.
let's
I have that we have been having this minas for a very long time. And yesterday at 2:30 they were doing construction right outside my house. So it was getting up out of out of hand. So I usually am not
एक
a Facebook
जागरूक
warrior, but this was
जागरूक
getting out of control. So
Yes, sir.
जागरूक नागरिक. Please continue, sir.
Jagrak Nagi.
Yes,
yeah,
yes.
जागरूक म्हणजे इच्छा नसताना जागरूक असं होतं ते. Okay.
Sir.
So I'll be talking about so this is what we see. This is a 45-year-old female patient, known case of diabetes for 6 to 7 years, and she presents to us, and this is what we see. These are the reports that a lot of patients come to us with, having done OCT elsewhere, and a lot of OCT machines have fundus camera nowadays, which take central photo, and this is what we see. Now, based on this, you would
Mhm.
probably tell the patient that, okay, everything is good, and you send the patient home.
Sir, Manish sir, sorry to interrupt. Would we have it on a slide
Yeah,
view
sorry.
mode, please? Thank you.
Is this good?
Yes.
Yeah, thank you. So based on this, probably you would tell the patient to, come back after 6 months. But this was a patient where if you do angiography, you are able to pick up neovascularization, and the patient, since she has moderate control, this needs panretinal photocoagulation. So the topic of my discussion today is whether what is the relevance of fluorescein angiography in the era of OCT and OCT angio. Nowadays, a lot of retina surgeons very proudly say that, we have almost stopped doing fluorescein angiography. And I tend to I beg to differ with most of them. So, this is my presentation about why I think so. So this is just a begin with. OCT, I mean FFA has started way before OCT came into existence, almost 30 years before, and that has been the gold standard since a very long time. In fact, when I was doing my fellowship, we did not have access to OCT at all. We started working which was brought into existence in 1991, and by the time it took almost two decades for it to become popular, and since then it has become a very important investigation in retina practice, as all of us know. And OCT angiography, which has been there since last almost a decade. So everything has its own importance, but FFA has not really lost its importance as far as diabetic retinopathy practice is concerned, is what I think. And the reason I think is that the things which are detected by FFA only are leakage detection, FAZ assessment. Yes, if you have access to OCT-A, you can still make it out, but the kind of image the FFA gives, the overall view the FFA gives, the standard OCT angio machines do not. So let's look at these images. So the leakage detection, the microaneurysms, you can make them out on OCT angiography, but we can actually see the leaking microaneurysms on FFA, and we can correlate it very clearly. Now, if we look at the picture in the right eye, what we can see is that there is this aneurysm, which is what are called as telcaps or telangiectatic capillaries. We can do focal laser, and this will be taken care of without giving any injection. So this is something which we can pick up on FFA, which may not be possible on OCT angiography. Now, this is a patient who has undergone panretinal photocoagulation in the past. He is a young patient who has come with poor visual acuity, and he actually had a vitreous hemorrhage in other eye. vision in this, I was 6/18, and despite having fairly good clarity and fairly good retina, unless we do angiography, we can where we can see the ischemic maculopathy, it's not possible to pick it up. And here again, we can see that there is neovascularization which needs additional laser. We can actually map the areas of capillary non-perfusion and make sure that they are all well covered by doing laser. When we are doing pan-retinal photocoagulation, there is something called as directed photocoagulation or directed retinal photocoagulation, which also we can do it with good mapping, proper mapping of capillary non-perfusion areas. And this can only be done when we are having a fluorescein angiography, and unless we are doing ultra wide OCT angiography, it it's not really possible to pick it up. But this is my standard fundus camera, and we can see that we can easily make out that there are areas of capillary non-perfusion, which areas which can we need to do laser for. The extent of neovascular activity. Now, if you just see the fundus of the patient, yes, we can see that there is some fibrovascular tissue is there. There is some neovascularization is present, but unless we do a fluorescein angiography, where it lights up like a Christmas tree, we cannot really make out as to how much severity is the extent. So it's also useful, as I showed you in first patient, it's also useful in macular edema assessment. We all know that OCT has excellent, it's the gold standard investigation for diabetic macular edema. But FFA is important because we can differentiate leaking microaneurysms from diffuse macular edema. It identifies exact leaking microaneurysms or telcaps, and for which we can do great laser, as I showed before. It documents the pattern of leakage for treatment for follow-up and evaluates the breakdown of inner and outer blood retinal barrier. While the OCT can make out fluid which is there inside or subretinal, it can see the edema volume, and we can monitor the treatment, but the FFA still has a role in these patients, and it should be done as a baseline. So here is an example. Here we can see this is enlarged image where we can see a telcap, and where if we just need to laser to this, it will be taken care of. While the other eye of the patient, where we see that there is a diffuse edema which can be picked up, and this probably would require, or this did require intravitreal injection. So we can actually assess where the edema is coming from and then treat it properly. So we have already seen this role of FFA in retinal ischemia and neovascularization. We have seen multiple examples of this in earlier areas, but the greater the capillary non-perfusion areas has higher risk of neovascularization, and this is an important factor. So if there are large capillary non-perfusion areas and there is very small neovascularization, but patient is having very poor systemic control, and the patient may not be able to come back, it's a good idea to do pan-retinal photocoagulation in some of these patients. So we all are aware of various studies which are done with Western population in like drcr.net, where they have done injections even for neovascular PDR. But in our scenario, where patient may not be able to come back as and when necessary, as told by the studies, and which is often the case, it's better to do laser for such patient if there are greater CNP areas. Now, you are going to definitely miss it if you don't do fluorescein angiography. So I think we have gone through the neovascularization at disc and at elsewhere. We can actually, as I said, there is guided PRP laser therapy that we can do, and also the IRMAs, the intraretinal microvascular anomalies which do not leak, we can differentiate it from neovascularization elsewhere only on FFA. So this is the micro aneurysm dynamics, which is a prognostic biomarker, which we can pick up with FFA alone. Yes.
Hello?
Am I going over time?
No, sir.
No, sir, you're on time.
No, sir.
You
No,
continue.
Continue.
There are some associated pathologies, like if you see the left eye fundus, there is an extensive asteroid hyalosis, and fluorescein angiography is probably the only investigation where we can see the retina properly. We can visualize the retina because the wavelengths are not blocked by the asteroid, and we can get a clear picture of the retina and then treat it accordingly. Here, the patient is having a severe NPDR with leakage at the macula. This is a patient who's having PDR along with parafoveal telangiectasia, and where we can see that there is a neovascular membrane. So this is stage 5 PFT with PDR, where we have to not only treat the membrane, but also keep a watch on this. Even if you are treating this patient with anti-VEGF, and that might take care of the neovascular part of the PDR also. But we have to be careful that once the membrane has come under control, the neovascular disease can still progress, and we might have to do PRP for this patient. In fact, the other eye of this patient had PDR. The patient had stage 3 or stage 4 PFT, and that despite not that required panretinal photocoagulation. So, how does OCT and OCTA have, where they have surpassed? They have surpassed in edema quantification. Outretinal anatomy cannot be seen by FFA. It has to be seen by OCT. Then we can see how we can treat the treatment monitoring, how the macular edema is responding. The vitreomacular interface, if there is any tractional maculopathy is present, etc., cannot be picked up with FFA, and we have to have OCT and OCT angiography. OCT angiography is having benefit that is non-invasive, and it has very high repeatability, and we can pick up the various capillary, the capillary plexus in various planes in ANFAS evaluation, while the FFA has been there for a very long time. It gives us full extent of capillary non-perfusion areas. FAZ morphology can be picked up, as I said earlier, by both, but neovascular activity, microaneurysm leakage, picked up on OCT angiography. We need FFA for this. So this is one patient who's having a PDR, where we can clearly see the difference between the FFA is the same patient who has undergone the fluorescein angiography and OCT angiography montage imaging, where we can see that the difference in the neovascularization as seen on OCT angiography and fluorescein angiography, where we can see the areas of leakage vis-a-vis, we can see these beautiful vascular networks on the OCT angiography. This is another patient who had lipemia retinalis, and he had poor vision, the cause being the ischemic maculopathy, which is very well seen in deep capillary plexus in the OCT angiography as well, and it correlates beautifully on the combined picture. So wide field fluorescein angiography, I don't have personal experience because I do not have access to it, but it has definitely a lot of uses, as we can see the areas of capillary non-perfusion in peripheral retina. And more than diabetics, I think it is very useful in vasculitis patients, where often the capillary non-perfusion areas or neovascularization are in the far peripheral retina. Benefit in as far as the diabetic retinopathy is concerned, the patients who are having repeated hemorrhages, if we do wide field fluorescein angiography, we can see capillary non-perfusions in peripheral retina and do targeted laser therapy for that as well. So these are the current clinical indications, and I must say that this is I'm sorry, this slide does not really show well, but the key takeaways are the fluorescein angiography and OCT are complementary; they are not competitive. But and FFA, even with the advancements in the imaging technology, FFA remains relevant in diabetic patients. While OCT and OCT angiography are, they're repeatable, they are safe, they are fast, etc. But there are certain areas which can only be seen well by FFA, and it's not obsolete. It has to be tailored for the patient and used, if used selectively and purposefully, it can definitely benefit us in, better management of the diabetic patients. Thank you.
Thank you, sir, for your talk. I think we can take certain questions. Panelists, do you have any questions? We can discuss it out. I think FFA is gold standard. Whatever might be the new modalities, FFA will stay forever. What, Rahul sir, do you have any comments regarding this?
Sir, Manish sir, and Manoj sir, and well, I do accept it that FFA is do needed. It's not definitely it has a role in today's practice, but considering that we all have this capacity to go for the Whitefield Octa to purchase them, maybe Silverstone or newer this Dream City kind of things. And what is I need to understand from you that these newer machines have this color coded flow density maps and also perfusion maps. Some of them are also giving you ischemia mapping and the velocity related visualizations also, which can mimic the leakages just like FFA. So do you see that in the coming time we are actually going to sell our FFA machines and it will be completely replaced with the these AI-driven wide field OCTA machines? Uh, Manoj
Yes,
sir,
sir.
Manish sir, and
The thing is that the evolution has occurred over a period of time in the field of ophthalmology or in the medicine. When any new technology comes, everyone rejects it or do not accept it immediately. But what the ultra wide field angiography with OCT angiography has shown its presence and its utility. We know that right now our talk was whether it is we have come to the level that Manish has given the talk whether utility of FFA in today's era. That means we have come to that thought process whether it will be required or not. Definitely with the time within a 2-3 years itself, this ultra wide field OCT angiography will definitely going to do the maximum share of the angiography. Maybe we may not say 100%, but maximum maybe in the 95% or above that. If you see the structural changes on OCT plus OCT angiography, your most of the job is over. Practical job is over. For the research purposes, obviously there is a no limit to the angiography, dye angiography. And one more thing is that the thing is that the availability. What happens in India and particularly in various places, the angiography, fluorescent angiography is available with low cost, even though the risk versus benefit, the risk of anaphylaxis and the complications with the invasive technique versus non-invasive, it remains still it is cheaper as far as the real world scenario goes. By the time the OCT angiography, wide field OCT angiography will cost more than 2 crores. So who will pay for that? And the recovery from where? The patients obviously every time you will like to have this utility of in your practice, and the burden will be on the patient and to the doctor itself. So, but definitely it is going to be the future.
A quick take on
Uh,
from Shashank
the
sir.
availability of the sodium fluorescent dye is also one of the reason. मेरे सब expire हो जाते हैं when I call Sagar, उसके पास की भी expire हो जाते हैं. So sodium fluorescent dye is also sometimes not available at that time when patient need FA or
That's true.
As Dr. Sasaude said, that I think it's important that patients who are, there are certain patients who come with obvious proliferative diabetic retinopathy. There you do current OCT angio machine that you have, you do OCT angio machine to map the ischemic maculopathy, that's fine, you are going to do laser. But there are patients which are borderline patients. If you can afford wide field OCT angiography machine where you are able to give it to our patients at affordable rates, I think that's the best of the both worlds. But if not, I think we should do fluorescein angiography, at least in, till the time, as Dr. Sasode said, till the time that the technology becomes affordable, it becomes accessible to us. These borderline patients, because I have seen patients who have gone back, uh, they have been seen somewhere a few months or few years back, and they have come back to me with bad TRDs, vitreous hemorrhage, etc. Where if they were picked up earlier, probably simple laser would have saved the sight. So till that time, we get the best of the, best of the best technology at rates, at cost that is justifiable. I think these borderline patients, we should do fluorescein angiography, and so that we are probably going to save sight, save vision for quite a few borderline patients. I'm sure there will be a lot of people who will be, uh, they feel that, it's too risky to do it because of the risk of anaphylaxis. But frankly speaking, I end up doing close to 7 or 8 fluorescein angiographies per week. And I have not really had any anaphylaxis in last 21 years of practice. Touch wood. Some patients definitely get some little bit urticaria, some get little nausea. But if you get urticaria, if you get some rashes, you just give one Decadron and they are fine. I mean, it's a fairly well managed thing. But I think a lot of patients are being lost in this, with the intent of, with the practice of not doing fluorescein angiography.
The thing is that, Rahul,
Yes.
what
Yes,
happens,
sir.
this is an investigative modality. Angiography, whether it is OCT angiography or dye angiography. Why we do? We want to disclose something or unmask something. So, and everyone should know that what was your upcoming. The Pangarkar sir is there, myself also. When I was not having fundus camera at that time, but I was having little bit idea about the fundus fluorescein angioscopy. With
Yeah.
indirect angioscopy, with blue filter, I used to do the angioscopy and I used to manage the cases. So there is no limit to the science. You should
True.
be well versed with the all technologies and aware of those things. And this is what the technology is upcoming, same way you are also upcoming. You should not forget your past also, how you have started your practice, and should not go directly to the OCT angiography, wide field angiography. Should not underestimate the things. Whatever it is available, use it judiciously.
Yeah, 2 words of wisdom from Anand sir about this. The AI-driven color-coded perfusion maps coming up in the OCTA. Do you see it is replacing FFA in this near future?
See, a lot of discussion about the advantage and disadvantage of FFA. I have never felt very comfortable saying for or against. Everything is complementary. Till such time we can afford to have OCTA and even the patients can afford OCTA and wide field one, FFA has a role. For example, if the patient is coming as a naive patient to you and you have done angiography, it will delineate all the neovascularization, the capillary dropout areas, and you will be able to plan out your laser treatment. So this way, the role of FFA cannot be diminished. There are certain concerns about the anaphylaxis, but I feel that they are exaggerated. I have never had any anaphylaxis so far, maybe about 3 to 4,000 angiographies. Second thing is about these newer techniques. See, when I first spoke in Cochin AIOS, at that time I had spoken about OCTA. And within 7 8 years, OCTA has become possible. So also these with AI driven thing, you will be able to have those flow
Yeah.
charts. You will be able to you will be able to predict velocity. You will be able to predict even the sluggishness of the situation, the circulation, and perhaps predict that there would be a block. But that is 5 years, 10 years later. Till then, continue doing your FFA till you can afford to have OCTA and your patients can have. Without doing an FFA, between the choice, if the choice is between not doing an FFA and doing FFA, I feel FFA should be done.
One more concern is regarding these patients also have comorbidities like CKD. So doing repeated FFA may not be possible and can sometimes prove dangerous. So
That
that
is,
is, I think, one.
yes, yes. See, everything has its own limitations. So FFA also has that rider that your renal function should be good. Having said that, it doesn't preclude doing FFA in all patients of long-standing diabetes who may have some renal morbidity, but not to the extent that you cannot do FFA. Maybe with half a dose FFA, fluorescein dose, you can do CKD, you can do FFA, and perhaps after getting a clearance from the nephrologist. But that concern is well taken, and one should be aware of it.
We have had very good inputs regarding the FFA and its use in recent practice. Some of the highlights that I think I got, and most of the general ophthalmologists should know, is that FFA is not dangerous, and as it is perceived in most of the textbooks. And as Manish sir said, it is a very good tool. And as a retina specialist, I too uh, support that in young patients and patients who are otherwise healthy, and where you have a doubt the patient might have, maybe at presentation the patient has a moderate to severe NPDR kind of picture, which you might feel might progress to PDR soon, and patients sometimes don't realize in that young age whether the condition might worsen that soon. So FFA is a very good tool there to assess whether laser can be done early and some preventive measures can be taken. Thank you, Manish sir, for a wonderful talk. Next is Dr. Manoj Sasode sir, who does not need any introduction. He is well-known ophthalmologist and an eminent vitreoretinal surgeon from Aurangabad, Sri Sambhaji Chhatrapati Sambhaji Nagar. And he will be speaking today on approach to a patient with vitreous hemorrhage. I'll request Dr. Manoj sir to share his presentation so that we can move ahead with the schedule.
Is it visible now?
Yes, sir.
Yes, yes.
First of all, thanks to Sean, Rahul, Purohit sir, Shashank sir, and Shamik sir, and all my good friends and teachers from the Vidarbha Ophthalmological Society for giving me the opportunity to speak in this webinar. We'll be seeing today the approach towards the vitreous hemorrhage. Vitreous hemorrhage is a very vast subject and vast topic as such, where you know that the spectrum is very big. Before knowing itself, we should see that what vitreous actually is. It occupies more than 2/3 of the ocular eyeball. Its volume is almost 4 ml, and it consists almost 99% water, and 1% of the it is of sodium hyaluronate, chondroitin sulfate, fibrils or collagen fibrils, and in which the hemorrhage is entrapped, and the patient comes with the seeing the floaters and blindness. There are multiple causes. We know that of the vitreous hemorrhage. Depending upon the cause, we have to manage it. The vascular causes are the commonest one, like in the PDR, BRVO, CRVO cases, ocular ischemic syndrome, sickle cell retinopathy, macroaneurysms, ruptured macroaneurysms, hemorrhagic PCVA, ROP and FEVR, Coats disease in children, then peripheral exudative hemorrhagic choroiditinopathy and various types of vascular tumors. These are the commonest things, vascular common things, while the other etiologies of the vitreous hemorrhage are like a traumatic. Maybe it is a blunt trauma or a penetrating trauma or in written intraocular foreign body. Then inflammatory vasculitis with neovascularization can cause the vitreous hemorrhage. Then PVD induced vitreous hemorrhage is very common with or without retinal tears or horseshoe tear. Then blood disorders like maybe simple anemia up to the leukemia. There can be a vitreous hemorrhage. Then there are various types of vitreous hemorrhage after the cataract surgery, even after the trabeculectomy, and rebleeding after the vitrectomy. This is very common. Then other systemic conditions like the subarachnoid hemorrhage or the head injuries cases also can develop the Turson syndrome like things where the blood comes into the subalum space. Then the vitreous hemorrhage first complaint or the symptom is that seeing the floaters or flashes in front of the eye, and patient sees the blurring of the vision is very common. Then in such situation, if patient is having, depending upon the how much of the hemorrhage is there and where exactly it is, Depending upon that, the vision loss is there. So if it is in the macular area, then the sudden loss of vision, patient will come with the dark spot in front of him. Then in such cases, particularly the history is, there is no substitute to history. Thorough history itself will give you to the clue what it is exactly. If it is a sudden loss of vision, and then you have to think of certainly whether there is a retinal detachment or a vitreous hemorrhage in presence of a normal anterior segment, particularly if there is this type of thing. Then you should ask about the residence, where from the patient has come. If the patient has come from the Vidarbha, from that Gondia and all those cases where the sickle cell anemia is very common. If he is from Buldana or Washi, then we know that in such cases the dengue fever or hemorrhagic dengue is common. Again, the age of the patient, you have to see that the ROP and ROP sequelae are common in children, while diabetes, hypertension, myopia, trauma, antiplatelets therapy, like many patients are on the ecosprin and other things, or the patient is undergoing the dialysis. All those cases can be ruled out. Then diagnosis is by excluding the vitritis. Many a times vitritis is considered as a vitreous hemorrhage. So you should know that whether this is a vitreous hemorrhage and not the vitritis. Vitreous cells is different and RBCs are different. That clear-cut understanding should be there on the slit lamp itself. You can see. Then the density of the vitreous hemorrhage can be seen. On the basis of that, you can find out the age of the vitreous hemorrhage, whether it is a fresh hemorrhage or old hemorrhage, whether it is a chicken fat like hemorrhage or a fresh red color hemorrhage. And try to see the fundus after dilatation, and if it is retina is visible. If it is retina is visible, you can clear cut find out retinal tear, PVD, as well as BRVO cases or other pathologies along with it. Then in such cases, investigations are important because retina is most of the time is not visible. If it is not visible, then obviously the B scan comes into your rescue. You have to do the B scan, and then we will see what the findings you will see from on the B scan. Then if retina is little bit visible, then one can do the FFA OCTs nowadays. If it is not at all visible, then B scan. And if it is a trauma case, you can advise for the CT orbit and X-ray orbit to rule out the foreign bodies or in cases of tumors. And certain lab investigations are important. If in cases of the sugar, if it is a high sugar levels, hemoglobin in cases of anemia, peripheral smear to rule out the any blood dyscrasias. ESR also you should know whether it is a high viscosity blood, and then serum homocysteine levels to know the vitamin B deficiency are associated coagulopathies and bleeding times, clotting time, and so many things. Then what to do? Many million dollar question comes. What to do? Whether to observe or to intervene. This is very common questions and that is the distinction between the old generation and new generation. New generation, because of the advances in the vitrectomy, availability of the injections and laser, they will be little bit aggressive. While the old generation people will say that observe it. That they should know that how long to wait, why to wait, and how long to wait. These questions should be answered by the yourself first. Whether it is a treatable, then treat. Then what are the treatment options? One is anti-VEGF, lasers, barrage lasers, vitrectomy, surgery is there. Then the treatment of the systemic disorders. If it is anemia, you have to treat the anemia. If it is homocystinemia, you have to treat with it. And then properly schedule the follow-up. If it is not the one-time disease, many a times it is a chronic progressive microangiopathy. So in that situation, you have to schedule the proper follow-up of the patients. Then if you don't treat, or you should know that if it is you are dealing with the vitreous hemorrhage case, then you should know the what is the natural course of vitreous hemorrhage. There can be a complete absorption or a partial absorption. If it is, then you know that the hemorrhage is consisting of the RBCs. RBCs when lyse, they break up into the heme and bile salts. The hemolytic glaucoma, ghost cell glaucoma, or neovascular glaucomas are common in such cases. If the bile salt is there, then bile salt can cause a toxicity onto the retina. There can be a hemosiderosis because of the liberation of the heme component and associated damage on the retina. Then there can be, if you don't treat it and keep on wait and watch, then there is a worsening of the underlying pathology and patient will lose the vision forever. Then if hemorrhage remains there, it can develop into the proliferative retinopathy and cause epiretinal membranes, lamellar macular hole, full thickness macular hole, tractional retinal detachment, combined retinal detachment can develop. And patient will suffer a long-term visual disturbance and they may not be repairable again. Then depending upon the location of the hemorrhage, you should know that what type of hemorrhage it is, whether it is subhyaloid hemorrhage, whether it is subilem hemorrhage, or whether it is an intrajail hemorrhage. And its characteristics are very typical. If it is a subhyaloid hemorrhage, that is a shape changes with the shift in the head tilt. If it is a subilem, then obviously it is a taut hemorrhage and it will not shift it. And diffuse vitreous hemorrhage you can see on the slit lamp itself. Then investigations are very important. If it is retina is not visible, then do the ultrasonography. Ultrasonography in fresh hemorrhage may not be possible or not give any conclusive. You have to increase the gain setting and find out the diffuse hemorrhage or pinpoint echoes in the vitreous cavity. It will give you the information how much is the density of the vitreous hemorrhage. Again, it will give you the whether the presence of PVD is there, whether there is associated tractional detachment like this, or whether there is a retinal detachment along with it. Then in cases you can see this is a membrane here which is causing which shows that there is a traction on the retina. This is a incomplete retinal detachment with a layered PVD, blood layered PVD, and you have to distinguish it from the retinal detachment. Then if it is associated with intraocular foreign body, here you can see the shadowing intraocular. If it is a globe rupture, you can see the vitreous incarceration. These findings can be seen on the B scan itself. And here you can see the traction component on the B scan, and then you will try to avoid the anti-VEGF in those cases, and will try to approach is different by doing the surgery first. Then you should know that in the proliferative diabetic retinopathy, another important thing is that you have to do the, if it is possible, as Manish has told, do the fundus photography as well as angiography, if wherever it is possible. Here you can see that these are the neovascularization. The bleeding occurs from the neovascularization or from the breakup of the normal vessels because of the trauma, or there is avulsion of the normal vessel. These are the three mechanisms where from the vitreous hemorrhage occurs. So these are the new vessels where from the bleeding occurs, and angiography in many cases will help. Then OCT also is helpful nowadays. With the little bit of hemorrhage or inferior hemorrhage, you can see the severity or the traction of and the bands on the OCT even in presence of scanty hemorrhages. Then another role of OCT is that with the hemorrhage in Eales disease, you can see that there is a macular hole and subretinal fluid is there. That RD is there, which is hidden in the hemorrhage, which is possible by the OCT itself. Then the severity of the hemorrhages is different, and depending upon that, the management and approach differs. Here you can do the laser. In the second case, you can do the laser as well as anti-VEGF. While in the third cases, because of the multiple fibrovascular proliferation, you have to give the anti-VEGF and schedule the surgery. While in this case, right eye is having chicken fat hemorrhage, that is showing that it is old hemorrhage. But apart from that, there is a fresh hemorrhage also. So this case can be considered for the anti-VEGF. In another this right eye picture, you can see that chicken fat hemorrhage is there, but new bleeders are there, and they are starting bleeders. So anti-VEGF plus laser will help in those cases. While this is a case with the vitreous hemorrhage with the tractional detachment. Once you give the injection, you can get the crunch phenomenon and detachment. While the other, we learn from that, and despite of hemorrhage, we did the laser, and that other eye is doing well. While there are very straightforward cases, this is the case of florid neovascularization of the disc with the hemorrhage, and no disc and macula is visible. So in such cases, take the fitness for the surgery. After getting the fitness, you give the injection and schedule it for the straight away for the surgery. So the approach varies even if all those cases are PDR cases. Here again you can see the dense hemorrhage, and here definitely if you don't do the surgery, this proliferative vitreous retinopathy will progress and patient will land up with the tractional detachment and lose the vision. Here again you can see the vitreous hemorrhage with the retinal detachment because of the proliferative vitreous retinopathy. Then if you don't treat vitreous hemorrhage, you can see this, what is the end stage? These are the proliferative vitreous retinopathies and tractional detachment and advanced diabetic eye disease has been developed. In certain cases where this is a fresh hemorrhage, there you can manage with the laser as well as the injections. This is again a case of fresh vitreous hemorrhage has been started. I have done the laser as well as injection, and patient is doing well. This is the case where the earliest stage of vitreous hemorrhage has come. A patient with the few hemorrhages has come with the symptoms of floaters, and then immediately we did the laser and injection. It's doing well. While in cases here, there was a fibrovascular proliferation, still we have given the injection and we will end up with the tractional detachment and has to undergo the surgery. Then if you don't do the injection, then there is another variant is of laser. Laser wherever it is possible through the hemorrhage or to the available visible retina, that is called as a laser to the available visible retina, you have to start doing. Then there are techniques of laser, you know that. But one thing is that in all those proliferative retinopathies, whether it is a PDR or BRU, CRU, you do the proper laser, it will save the patient from blindness. We know that with the track history of 20 years almost, the patients are doing with the good laser. But if you don't do the good laser, then obviously there are escape areas, and still, as Manish has shown, the angiography will help you and to advise do the lasers. And the laser obviously has a techniques we will see. Despite of doing the laser or incomplete, not done proper laser, then the proliferation keeps on increasing and the hemorrhage occur. So this is we know that diabetic retinopathy is a progressive microangiopathy. There should be a keep under periodic follow-up. Patient should be under periodic follow-up. Otherwise, you know that these are the well-treated retinas. Till the vitreous hemorrhage has been developed. The approach is different now. You have to take the help of the injections apart from the fill-in PRP. Then this is the case. You see that the difference in the treatment. This is a simple vitreous hemorrhage, fresh vitreous hemorrhage. In a well-treated case, you can still take a chance of giving the injection. While here also there is a proliferative retinopathy, but the macula is attached. You don't have to give the injections. Otherwise, it will cause the crunch phenomenon. Patient will lose the existing vision with the tractional detachment. Manage still with the fill-in PRP as long as it is possible. Here also in the right eye, you can see the tractional detachment with old vitreous hemorrhage. You straightway approach is to do the surgery. While this one, despite of looking very horrible in the right eye, macula is still attached. It is extramacular TRD. You can manage with the laser. Then in such cases of advanced PDR, you have to go for the surgery, and you know that there's pre-op and post-op pictures. These are the pre-op and post-op pictures. Then another vascular retinopathies like BRU, CRU cases, obviously in such cases hemorrhage occurs. Then the line of management is by the laser as well as the anti-VEGFs. These are the macroaneurysms which can cause. Then ocular ischemic syndrome is one of the cases where there is, apart from the vitreous hemorrhage, there is a risk of neovascularization over the iris and causes the neovascular glaucoma. So in such cases, obviously you have to be very little aggressive. In homocystinemia, you know that the treatment can be with the B12 injections. In anemia, you have to manage the cause of anemia and anemia itself. Then first, most of the important thing is that not all hemorrhage is vitreous hemorrhage. You should know the exact location of the hemorrhage. Here, this is looks like a vitreous hemorrhage, but all hemorrhage is subretinal or sub-RP hemorrhage. So this is a ARMD with wet ARMD with subretinal hemorrhage. While this is a PCVA with all layer hemorrhage, in such cases approach is different. Anti-VEGF, apart from anti-VEGF, you have to give those SF6 plus TPI, and the patient's record should be kept very meticulously so that you know that what you have done and how he is responding. And we know that from October 21 to till date, the patient is happy because of the proper management. Here also peripheral exudative hemorrhagic chorioretinopathy cases, hemorrhages are there. We manage with the laser as well as the anti-VEGFs. Then the cases like Eels disease and or sickle cell disease in Vidarbha. You know that there are CFAN like neovascularization which causes the hemorrhage. In those cases, apart from sickle cell anemia, you have to treat with the anti-VEGF and lasers. Then Eels disease are also still common nowadays. Then papillophlebitis or vasculitis cases, you have to investigate thoroughly with the systemic investigation, RA, ANA, CCP as well as HLA B27, HLA B50, and find out the exact cause of the disease, whether it is tuberculosis or other, and then treat them properly. That approach is more important than the ocular treatment itself. Ocular treatment goes hand in hand with the systemic treatment in such cases like in sarcoidosis, in SLE, as well as other cases like, see, this is a sarcoidosis case. In such cases, obviously, more burden is on the systemic management than the ocular. Then in cases of this was a posterior scleritis case where the neovascularization developed and caused the vitreous hemorrhage. This is another case like hemorrhagic dengue. These cases are were very common from the Buldana and Risod area, but now they have reduced. Then another commonest cause is PVD induction. This was a PVD induced vitreous hemorrhage on the 14th September. We observed, and on 17th September he came with the flashes of light. We know that now that horseshoe tears were developed. So PVD should not be ignored. Ask the patient to keep on periodic follow-up till the complete PVD occurs. And while there is jerky movements of the vitreous or in the vitreous cavity will cause the tears where there is a plastering of the vitreous, and we did the laser. This is very common in cause of the PVD induced vitreous hemorrhage and retinal tears. You know that the retinal tears occurs along with the large blood vessels. Obviously, they causes the vitreous hemorrhage. I mean, we have to treat with the laser barrage if they come earlier. If they come late, if you ignore, then the retinal detachment occurs. Then obviously patient has to approach is different. You have to go for the surgery. Then systemic conditions like cavernous sinus thrombosis also can cause the vitreous hemorrhage as well as orbital hemorrhage. Then this is a case of bilateral Terson syndrome with the sub-ILM hemorrhage. In such cases, approach is different. We know that why this Terson syndrome has occurred because of the CNS pathology, whether it is a trauma or whatever it may be. First, stabilize that one and then ask the patient to come to the ophthalmologist. Till that time, wait and watch policy is not harmful in such cases. If patient is still in a hurry, you can do the laser hyalodotomy and drain out the sub-ILM hemorrhage. Then there are certain cases like radiation retinopathy with neovascularization and hemorrhage. Then ROP cases, FUR cases also can develop into the hemorrhage. Here you can see that this was the ignored case and hemorrhage has been developed. Or in cases, if these SPR cases also, FUR cases can develop the hemorrhage and you get a surprise on table after at the time of vitrectomy that this was a case of FUR or it was a case of PCVA. And these cases like long-standing cases of Coats disease also can come with the vitreous hemorrhage. There are certain cases of angiomas which bleeds and cause vitreous hemorrhage. So all these possibilities should be there. And this commonest causes nowadays the whole society is very aggressive. Young generations are very aggressive and they keep on quarreling on table or on the beer bars also, and they come with this types of hemorrhages and vitreous hemorrhage, retinal tears, coronal ruptures, and all those types of things. When should and the domestic violence is also common. If you read the newspaper every day there will be one page on this violences, and these cases can be managed or observed depending upon the litigation. If it is a litigation, obviously do the laser hyalodotomy earlier and this patient can get the vision recovery within hours. This is the case of pressure cooker injury to this man and cause the retinal tears. Here you can see the vitreous hemorrhage with the tears. If it is visible, treat it with the lasers. Then this is a globe rupture case with the retinal detachment. Yes, here obviously the approach is different. You have to manage the anterior segment tear as well as the same sitting. You have to do the retinal detachment. Then retinal tears because of the dialysis, because of the trauma. Then retain intraocular foreign bodies. Here you can see the wound of entry. Here you can see the foreign body on the B scan, and these are the foreign bodies inside with the vitreous hemorrhage. So the history is important. And meticulous history is important. These are the foreign bodies with the vitreous hemorrhage, and sometimes you get the infection also. These are the cases where the drop nucleus along with the fishing. If you do the fishing, more fishing, you come out with the vitreous hemorrhage along with the drop nucleus. There are the cases with SICS on the patients or on the ecosprin or hemolytic drugs. Then when hypema occurs on table or on the next day, then because of the hypotonia and all those things, the hemorrhages can occur, hypema can occur, and vitreous hemorrhage can occur. If there is a trauma to the ciliary bodies are handling, then also in anterior segment surgeries you get the things of vitreous hemorrhage. Then the commonest cause of the vitreous hemorrhage, if you do the wrong side block or your new anesthetics or the junior anesthetics develops, then they should know the technique of giving the block. Otherwise, the patient will lose the vision forever. That's all. So there are multiple etiologies of the vitreous hemorrhage. So multiple etiologies are there. So the approaches are different. It should be tailor-made, and you should have a judicious approach to the every case. It's not that the wait and watch is possible every time, or it is not the aggressive management of surgery on the first line of therapy. So depending upon the given situation, whether it is a trauma case, litigation case, or a proliferative vascular case, or a post-op case, depending upon that, give a correct approach to these things and manage. But the most important thing is that vitreous hemorrhage is a sign of the underlying disease. So the main problem, you should find out why the vitreous hemorrhage has come and address that one, either with the laser, anti-VEGF, or with the surgery. Thank you very much. Thank you, Sean, and the team for giving me the opportunity to speak here. Thank you, sir.
Thank you, sir. It was a very extensively described talk, and the thing is that yes, obviously, all vitreous hemorrhage doesn't require injections, or all vitreous hemorrhage doesn't require vitrectomy, and there should be a approach-based treatment. So we had one question from Prashant. Respected sir, nowadays lasers in DJ and marriages processions is very common, causing focal sub-ILM or pre-retinal subfoveal or macular hemorrhage in young patient. What is your take on that management? Thank you. I think you already described, but please elaborate.
In those cases,
The
that
laser for
DJ
Hmm.
related, no?
Yes, sir. Yes, sir.
Manish is there. Manish will answer it properly.
Okay.
Manish sir,
Yes, sir.
yeah, your DJ related hemorrhage, you can answer it properly.
Well, DJ related hemorrhages, I think we need, these are subhyaloid hemorrhages in most of the cases. We can wait and watch if there is no foveal involvement. Sometimes it might be associated with macular hole formation also. If there is any macular hole or is seen, then obviously you have to take it up for early surgery. These are subhyaloid hemorrhages. They are amenable to laser hyalotomy, YAG laser hyalotomy also. And otherwise, in extreme cases, we may have to do vitrectomy and remove the sub. These are basically sub ILM, so you need to do ILM peeling and treat it. But uh, they can be associated with underlying retinal trauma, and so you have to be very clear when if you are going to operate the patient. Be very tell the patient about guarded visual prognosis, because unlike the Valsalva retinopathy patients, where underlying retina is most of the times clear and you are going to get good visual acuity post treatment, whether laser or surgery, these patients may have underlying retinal damage, and the visual prognosis may not be always as good. So we need to be careful about it. Yeah.
Yes.
I have a very experience about this DJ business. I feel it all depends on how much has been the exposure. Most of the times in my cases, it was subhyaloid hemorrhage, and it did well with YAG laser hyalotomy with good visual recovery, and perhaps a lesson for the young boy to be away from the DJ and those laser lights. But if that exposure is prolonged, then as what Manish has rightly said, that there could be underlying retinal pathology and damage, and then the prognosis won't be good. But it's a serious nuisance.
Yeah, and not just marriage and these processions, even
Any
these.
occasion, Manish. Manish, any
No, no, no. What
occasion.
I'm saying
Nowadays,
is, sir, even these handheld laser pointers, kids are
ah,
using it as
yes,
toys.
yes.
They are sold as toys. Actually,
Oh,
I have a publication in Journal of Pediatric Ophthalmology and Strabismus, where we had presented a small child who had a handheld laser causing subhyaloid hemorrhage, and I could do laser for that and treat it. But the point is, even these handheld lasers, we have to be careful about them.
yes,
We have
they
to.
carry a big. They used to carry a big warning when we used to use them for presentations, and I never knew that they have become now toys. I was also only sort of aware of the road shows and the DJs.
No, no,
Anyway,
they are sold as toys now, sir, nowadays, sir.
oh
And
my
very
God.
cheap ones at that. That's very risky.
Yes, 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 yes. Very cheap. Chinese have made everything very cheap.
I feel we
Get
should
on
move
to
on
the
to
next
our
presentation.
yes.
Yes.
Dr. Rajesh Ugle sir, a dear friend and a senior from Akola itself, will be speaking on management strategies in CSCR. Over to you, sir.
Okay, thank you, viewers, and thank you, friends, for allowing me this topic and for this talk. So this is more like a general ophthalmologist, what he should do while managing in their daily OPD, and if you see a patient of CSCR. So we'll go through the simplified and evidence-based CSCR management strategies. So by definition, CSCR is a serous detachment of the neurosensory retina at the posterior pole. The main pathology is leakage. I'm audible.
You are audible, we can't see you. Dr. Manish. Okay, please go ahead.
My video is on, sir. It's a leakage to the retinal pigment epithelium, and impact is primarily at the macula, so leading to the visual disturbance, and each patient has to come to the OPD. And now in 2026, we recognize this as a pachychoroid spectrum disease, this entity. Now we'll discuss that afterwards. Epidemiologically, male are 6 times more likely to have affected than the females, predominantly young, middle-aged, 20 to 50 years of age. Strong association with type A personality and high stress level. Risk factor and history check. As Manoj sir has already said, history taking is very important in vitreous hemorrhage. So here also the role of history taking is very important. I usually spend 5 to 10 minutes to ask each and every history in case of CSCR. Main culprit is steroid. Corticosteroids are the number one modifiable risk factor actually, and that includes oral, systemic, nasal spray, inhalers, topical cream. In any form of steroid, they can cause CSCR. Other culprits are PDEF inhibitors like sildenafil, sympathomimetic agents, Ayurvedic and homeopathy. I call them supari drugs because their hidden content is steroid only. So many young patients who come with the gym supplements and homeopathy and Ayurvedic medication for any other disease, they have this CSCR. So history taking is the most important diagnostic tool. Other risk factors are hypertension, pregnancy, organ transplantation, genetic family history, hyperopia, and H. pylori infection. Pathogenesis, as it's so simple, it's always a sequence. It's a choroidal hyperpermeability, congestion of the choriocapillary. You can see in the image, the RPD is the breakdown of the outer retinal blood-brain barrier and subretinal accumulation of the fluid, causing a neurosensory detachment. That will Here I will just describe the pachychoroid spectrum. It's a group of eye condition likely linked to thickened choroid, pachychoroid, and dilated vessel, pachyvessel in the outer choroid, resulting in the damage to the retinal pigment epithelium. There are commonly we use CSCR, pachychoroid pigment epitheliopathy, pachychoroid neovasculopathy, and polyploid choroidal vasculopathy. This is important for the management point of view, and this is just a pachychoroid spectrum. Visual presentation is usually often patient come with a blurred patch while reading or driving or while watching TV. He may complain this metamorphopsia, micropsia, and central scotoma. Diagnostic is multimodality, but OCT is the main tool here where we can diagnose. You can see the OCT image where neurosensory detachment is there, and you can see nicely the dome hill appearance where we can see the subretinal fluid. PED and increased choroidal thickness you can see here. FFA, as Manish sir already said, FFA, role of FFA. Here also role of FFA is coming now to identify the exact leaking for the laser. You can see the FFA picture where we can see the ink blot pattern or smoke track pattern. Here ink blot pattern I have shown. ICGA is crucial for identifying the pachychoroid congestion. Though personally I don't have any experience with ICGA because I don't have ICGA, but it's very important from treatment point of view at it will help for the PDT treatment. So we divide the CSER usually into acute and chronic. Acute we can call if it is less than 3 to 4 months duration. More than 3 to 6 month duration, it's a chronic CSER. Visual outcome is usually good in acute CSER. Chronic CSER, it's variable, permanent loss can be there. RPE status is focal leak. In chronic CSER, there is a diffuse RPE atrophy and sick RPE. So management acute CSER mostly observation and lifestyle changes. Chronic CSER we have PDT, micropulse and anti-VEGFs. So we will go back step by step. Acute phase 1 to 8% so observation is the first way. Modification is stop all the steroid immediately, address the sleep apnea disorders, and I usually give them the state reduction techniques like Raj Yoga meditation. So we have actually mind spa room only where our psychologist is guiding this patient and help them to relieve the stress. So use this strategy at our center. Many drugs has been used for the treatment of the CSER, but none is proved or further. All the RCT and they said further evidence need to prove it. Like antioxidant, mineralocorticoid, glucocorticoid receptor oral antagonist. Aspirin has been used, beta blocker. Here is a list of we usually give Dimox, carbonic anhydride inhibitor. H. pylori eradication has been given, methotrexate, even rifampicin also had been tried. But no evidence is suggesting that this drug is superior or that drug is superior. So chronic phase, we have PDT and especially half dose, half fluence PDT is very important. Now the PEN trial is, I don't know whether it is started or not. Manoj sir or Manish sir will tell us regarding that. But that trial will compare the placebo and the PDT effect, RCT, that is the RCT trial. So they are planning it in this year. So that will establish the role of PDT, half fluence PDT in the treatment of CSER. Another factor is the availability of the drug vertiformin for the PDT that is not available. So that also is one of the reason why we are not doing nowadays PDT. When the machine is available, drug is not available. Second is a micropulse laser, subthreshold treatment to the stimulate the RPE without damage, and that will cause absorption of the fluid. Anti-VEGF has limited role, primarily complicated CNVM cases, but I have used anti-VEGFs also, but they response transiently and again recurrence of the. So early treatment in chronic cases prevent the foveal atrophy. Risk and complication, if we don't treat in this chronic CSAR, there will be RP atrophy or thinning the foveal layers, CNVM development leading to the hemorrhage. Permanent loss, if SRF persists more than 6 months, the permanent vision loss will be there and recurrence is common in 30 to 50%. Monitor these patients with OCT every 4 to 6 weeks in your clinic. So take home message is steroid vigilance. Ask about the inhaler, nasal spray, skin cream, steroid, and that is a fuel for the CSER. Multimodal treatment. OCT is diagnostic. Nowadays, everyone is having OCT in their clinic. So OCT is very important in diagnosis and 3 months rule. Usually, most acute cases resolve. Do not rush the treat. Do not rush to treat the unless visually demanding professions are involved. And in chronic CSER, PDT remains the evidence-based choice. Micropulse is also safe, but it's a valid alternative to the PDT. Thank you for your attention.
Thank you so much, Rajesh sir, for a comprehensive talk on CSCR. My question is to all the panelists who are with us. So, for all the general ophthalmologist people, when a patient has a complete resolution with whatever medicines you gave for CSR at first presentation, he develops recurrence within the next 12 to 18 months or maybe 2 years. So, what is your line of management at that point of time? So, Dr. Shamik sir, Dr. Himanshu sir, Rahul sir, Ridhima ma'am, Prashant sir, Ayush, please give your valuable insights. Rajesh sir.
Can I? Okay.
Prashant sir?
Can I say?
Yes, Dr.
Yes,
Ridhima,
yes,
you are
ma'am.
audible. Go ahead.
Yeah, right. So generally, for a recurrence, we do an angiography, and if the leak is not subfoveal, we go ahead with the focal laser. The other modalities that we have is, of course, subthreshold laser, and if it's chronic, then PDT. But there is a lot of problem with PDT because the dye is not available. Second is micropulse or subthreshold laser. Again, that is not available at all centers. Another modality that we use when none of this is available is mineralocorticoid antagonists. Although I have had like 50-50 result with eplerenone. So you cannot say with 100% conviction that eplerenone will, but yes, in 50% of cases it has worked. So these are some of the,
Madam, my question to you is whether on first presentation would you just go with nipafenec eye drops or would you add dorzolamide eye drops at that point itself?
Generally what we've seen is in around 90% of patients, if it's the first episode, the fluid goes away on its own in 1 or 2 months. Because we've tried doing focal laser at first presentation, but eventually if you look at long-term BCVA, it has not helped at all. So first episode trying to treat with focal laser has not provided any advantage over maybe a placebo.
Okay. Rajesh sir, you may want to add something to this.
Usually we start with nipafenec, and antioxidant we usually give because that may have placebo effect, but frankly, after it takes 2 to 3 months to resolve the acute CSER. And for recurrence, I have given anti-VEGFs also. I have and almost 3-4 patients from Amravati. I have given them anti-VEGF. They resolved completely, but again after 6 months they come back with the SRF and.
The thing is that, Shubham sir, I will intervene in between.
No, sir. Please, sir. Please.
The thing is that the CSR is again a multifactorial.
Yes.
Psychosomatic versus the morphological.
Morphological.
See, if it is a psychosomatic disorder, then you have not treated it. That's why it has recurred after 1 year. That persistent psychological stress is there, or whatever may be the reason. You have to find out. Or if it is a morphological, if it is a pachychoroid spectrum of the disease under that one, then find out and accordingly you have to take. Otherwise, nepopinac and all those things that you have to do something, give something. A patient has been referred to a super specialist and he is going empty hand. That's why we are giving nepopinac. I don't know how it will help. It is not an inflammatory disorder. Same thing, antioxidant, it is not a deficiency disorder.
No.
So that is not the definitive treatment is that to find out the cause. The systemic as well as the local cause. If systemic is treat systemic, local, obviously the thing that pachychoroid or some leaking point is there. And if it is extrafoveal, there is no harm in treating it. No doubt that Ridhima or she has told that there is hardly any difference, but it is shown that if you do the laser, then the absorption of the fluid is rapid and the damage associated with the CSR, we know that it is chronic CSR, it turns into the chronic one. Then every time the RP becomes more and more sick. That's why it is better to treat, as long as it is in a safer zone to treat. Yeah, obviously near to the fovea or juxtafoveal or subfoveal, you can wait and watch.
History taking is important to find the
History
cause.
taking is important. There is a good presentation by one doctor from Mumbai who had access to both the psychiatry thing, and he found that yes, the type A personality does matter. I also do that. For the first 15 days, at least, I give him some anxiolytic drugs.
Yes, yes.
Second thing is about doing focal laser in case the leak is outside the FAZ. That depends on the patient as well. If he is very demanding, like I had one Patel fellow from Amravati, he was a one-eyed person, dependent, the whole house dependent on his ability to cut the tiles. So he said, no matter, sir, you treat it with laser. 10 years down the line, he had come. There was no recurrence. This time he came for cataract, and I advised him to get it done in Amravati. So depends on the visual requirement also. Visual requirement also. And laser is not a permanent solution, especially in case the patient has a pachychoroid and an underlying reason for its recurrence. But in case of recurrence, do a FFA, find out if the leak is elsewhere, and if it's a focal leak, you can always do laser. That subthreshold thing is a good thing. I don't have access to it. And fluid absorption or limiting the fluid's presence is very important, because then you are preventing its progression into a chronic thing. And of course, trying to salvage the best. The longer the fluid, the more the damage will be.
But it is that in all these things, what Rajesh has told, that Raja Yoga therapy and all those, we know that this is a typically 99% or 95% patients are type A personality, where there is
Yes.
We
original
usually
energy
send them
for
to our in-house
cortisol levels are
psychologist.
high. So in that situation, Raja Yoga and what you have said, that the anxiolytic treatment. Both
I have a girl
both
who
can
sleeps
be.
only 3 hours at night.
And unfortunately, this type of A personality don't listen to anyone.
Anything.
It recurs twice, thrice. Then they start doing the meditation and all those things.
So actually, it's very difficult to treat people who have chronic skin conditions or going to require steroids for the rest of their lives. Type A personalities. I mean, there is nothing really you can do about it.
Yes, obviously.
Counsel.
Yeah, just counsel and yeah.
This is the Raja Yoga and all those transformation, mental transformation.
Yes.
It is possible with those things.
But then now I have one source, Rajesh Shukla, to refer one, say, 30-year-old IT professional who sleeps only 3 hours at night.
Yeah, yes.
Sure.
Any cataract
we have
surgery has any link with how to plan cataract surgery in these cases, or any?
As Pangarkar sir said, you refer them to Amravati.
Amravati has a
So
special.
I was waiting for you, Himanshu sir. We have had two consultants speaking that patients with Amravati are having problems with CSCR management.
This
So
level
you
is
guys have to
Amravati is
have
very high.
I might be
this.
partly responsible. Tiles
Himanshu was operating one of them.
Stress level is very high in Amravati region, so they are coming to Nagpur and Akola.
And Dr. Himanshu is with us. No, sir, what is your opinion about the mineralocorticoid antagonist eplerenone? Do you use them? Do you find them useful? And what is an anti-VEGF in CSCR?
I believe our evidence is just type 1 evidence, and we have to respect higher level evidence. And right now, anti-VEGF, there's a study coming up with only 40-50 patients. Yes, that shows that for chronic CSR, that's not a very well powered study. Anti-VEGF, no, I don't want to. I'm sometimes forced to give, but CSR is, as Dr. Sir said,
We
it's all
have
about
the
history.
evidence for using anti-VEGF in CSR. I don't know why anti-VEGF is being used in CSR.
Because you have anti-VEGF available. But there's new study. I just saw in last few years, the BRIC study or something like that, 50 odd patients. That's a randomized prospective control trial. Which shows that there's a good reduction in fluid. In our apocryphal anecdotal cases, also there's a reduction in fluid. But anti-VEGF now, I think in a few years we'll have good evidence to suggest that anti-VEGF may or may not work. A lot of studies, if you look at the study site, a lot of studies of good RCTs for CSR and anti-VEGF. This study was done for brolucizumab, if I'm not wrong.
Yes.
Hello, I want to add two things.
Yeah.
Am I audible?
Yes.
Yeah. Usually in our area there is more tobacco chewing habits. So I found many people having in a belt with a lot of tobacco and in form of khara. So we have a lot of CSR coming to us. Usually, I have many patients of CSR coming to OPD, and in acute cases, whenever they come, I give nothing, just I give
Placebo.
eyesight plus or antioxidants or a NSAIDs, and 90% of time they resolve completely and they come in 1 month, or else just a small fraction of SRF is left. But in cases of chronic cases, I have given Aprenanon too, and Aprenanon has worked around 70% of the time for me. Of course, 30% of the time I didn't get any result, but it's a good medication for me to get rid of CSAR when they come repeatedly to my OPDs. In chronic cases, okay, if you see in the OCD, the double layer sign, so I consider giving anti-VEGF in such cases because that is the time I consider giving anti-VEGF, and that is an indication too when there is a double layer sign. Think of an added CMV into the component. So these things I would just wanted to.
Yes, yes. In your case, see the cause and effect. Type A personality. Then secondly, why he choose the tobacco and smokes more? Because of he is a
Stress.
type 1 personality. And instead of going to the remedy, he again keeps on taking the same thing. So that's why the CSR comes. The root cause is stress. Understand? Yes.
And females you see very less time. Yeah, female to get it, but in pregnancy, as in and those ladies which are taking steroids, I have seen coming to my office.
Supplements.
Very correct.
Even mobile addiction, they don't sleep properly. Many young patients, they are addicted to very games and all that. So they don't sleep properly. So few young patients have history of mobile screen time is more than 12 hours or 15 hours they usually have.
That's what it is. A CSR has a more of a lifestyle association. So you have to consider this as a lifestyle disease.
Thank you.
If I want the other panelists to be involved, I just wanted to ask a question. In the management of cataract in a patient with diabetic macular edema, so what would be your choice to pre-treat the patient before the surgery?
Patient with cataract and DME, you mean to say?
Yes, sir.
We generally go ahead with one injection and then an injection along with the
During surgery.
IOL surgery. So it will be 1 month gap between the two injections and then followed up later. This is what I've been following. But it can vary depending on how well the patient's diabetic control remains and goes ahead. Varies from patient to
Do you
patient,
have
but
any experience with
best is to give an injection along with the cataract surgery.
cataract surgery itself? Do you have any experience with Ozurdex, sir, before or at the time of surgery, cataract surgery?
I've reduced my injections of Ozurdex big time because it acts as good as IVTA. So I prefer giving IVTA instead of Ozurdex. It works the same.
Himanshu sir wants to add something.
Yes.
No, I don't. But my protocol is this: if there's peripheral ischemia, then I do PRP one sitting as much as possible through the cataract, because cataract surgery and the break down the blood retinal barrier and we get progression of peripheral ischemia. So I'll do one laser first. 10 days later on, I'll do a cataract and an anti-VEGF injection and see if there's further need of. So we will not prime with anti-VEGF first. We'll give anti-VEGF with cataract surgery. That reduces the number of procedures my patient needs.
3 days.
As he said, Ozurdex not with cataract surgery. I would rather give cataract with anti-VEGF. Ozurdex usually is always done standalone in my practice.
Okay.
So there is a debate between whether to give free of anti-VEGF or intro. So I just want to know what are the suggestions.
Pan-retinal photocoagulation for peripheral is always preferable if the cataract allows for it, if the opacity allows for it. And you can do it both ways. If there's a lot of macular edema and ischemia, I would rather give an anti-VEGF or an Ozurdex, wait for a month and then do cataract with anti-VEGF again. But if it's okay, then our go-to modality is to do cataract and anti-VEGF in one sitting.
So when you say peripheral PRP, do you mean peripheral PRP in DME in NPDR?
No. As
In
it
PDR.
is in as yes in PDR.
In PDR.
Or in PDR, yes.
For NPDR because
No,
NPDR
if it's a
patients
very nice
peripheral
periphery,
ischemia.
if it's a mild NPDR or moderate NPDR or just touching severe NPDR, we wouldn't do a peripheral laser.
But have you tried it, or have you seen the increased number of anti-VEGFs and the severity, subsequent, recurrences of DME?
Oh, yes, anti-VEGF. Sorry, I didn't get your question.
Peripheral PRP, targeted PRP in, let's say, a moderate to severe or a very severe NPDR, along with DME.
No, the severe NPDR that they don't receive
Not
as it
talking about
approaches
PDR at
PDR.
all. Not talking about PDR at all.
Okay. No, those patients don't receive peripheral pan-retinal. No, they don't even receive targeted because it's very difficult to find targeted in the presence of that cataract which we have. We don't do angiography preoperatively, fundus fluorescence angiography. So if there's if it is PDR, then we'll prefer to do laser first as much as possible and then cataract with anti-VEGF. DME would recur depending on the phenotype of the DME and the patient's control. That subsequently needs treatment.
My belief is if you get a patient of PDR, always don't do targeted laser, do aggressive laser. Because we have to be aggressive in PDR cases. Whether the patient will progress or not, that is the other question. But your target should be aggressive. What I believe.
See, the idea is to stabilize the proceed with another surgical intervention. So we do an aggressive PRP, wait for 3 weeks, 4 weeks, stabilize the retina, and then go ahead with cataract.
I think one thing we can add is to do gonioscopy before cataract surgery, specifically when there is uncontrolled sugar. Because if we get this NVA and everything, the management will be changed. So we have to do PRP first and then go for a cataract surgery. And that one thing we can do in case of uncontrolled sugar and form of NPDR cases also.
Even I consider giving in severe NPDR too, because we never know how it will progress. Because anyways, he is going to get progress to PDR after cataract surgery in few days or time. So better get it done initially, if the cataract permits.
Manoj sir, a question for
In a
combined surgery.
patient who is going to be a candidate for cataract surgery, the threshold level for doing laser, the quantity of laser that you would like to give should be more. Because if you have achieved, even if you have achieved good, say, stability, that will go down a notch or two after cataract surgery. That is the rule.
Manoj sir, a question for regarding the combined surgery, cataract plus VR diabetic vitrectomy. You will do it in one sitting or separate, first IOL, then VR, or what is your?
The thing is that why twice? It should be answered. And you should be justifiable whether the retinal condition is so aggressive, severe, that itself will cause a more inflammatory reaction, or if it is a simple vitrectomy with the cataract is going to induce the reaction somewhat, and retinal surgery will induce. So combined, we will see that what will be the effect, and that is the reason why we don't do combined surgeries most of the time. That was the dictum previously when I was a fellow. The cataract surgeons were doing the cataract first or later on, and the retina surgeon used to do The technique was different. Nowadays, because of the MIVS as well as the FECO, it's a mere matter of just minutes. And the damage which has caused by the cataract surgery itself, that is a reaction which has been induced in a diabetic particularly, is very minimal. So in one sitting, it is always advisable, provided that if it is a very debilitated person with the complicated diabetic retinopathy or advanced diabetic eye disease, CRD is there, TRD is there, subretinal hemorrhage is there, or and the patient is on the hemodialysis or some other very uncontrolled diabetes or with the ischemic heart disease or status post bypass surgery. In those cases, obviously you will do one by one because the reaction after the combined surgery is different. While in most of the cases I do combined surgery and I have found it's very easy and patients are also happy and you are also comfortable in doing both the surgeries provided you are done the mastery in both the things. Second thing, the vitreous surgery becomes very friendly after cataract removal. And most important that what is going to happen within a month or two, the patient is going to come with the cataract after vitreous. That is the rule. You put a gas or oil or even
Yes.
if it is not put. Then obviously for a patient, he has not come out of the first surgery and you are asking him to go for the second surgery. Your results of retinal surgery are not yet out. And by the time the cataract becomes on the forefront. So it is always
It is much better to do the cataract than
combined
wait for a
surgeries
month.
are nowadays a rule everywhere in the world.
Just a small doubt, sir, and I beg to differ from your view. But when we most often take our patients for an intravitreal injection before a diabetic vitrectomy, maybe if it is combined or it is just a simple diabetic vitrectomy, I feel it is taking the same amount of risk as operating a cataract nowadays. So in my practice, what I do is I club the cataract with the intravitreal injection and then follow it up later in 3 to 5 days for a vitrectomy. It saves me time. It saves the patient a bit of trouble because of the prolonged duration. And somehow I feel combining both the procedures is uh, it takes some amount of time for you to shift between the procedures, and that is what extends the procedure and makes it little more uncomfortable for the patient and the surgeon both.
Yeah, if your concern is the time between the two procedures on table, that is maybe because of the changing the cassettes. Otherwise, you know that the vitrectomy cassette,
Combined cassette.
combined cassettes are
Combined.
there, and even if your people are trained that this is a combined case, then my assistant is always ready with the second vitrectomy cassette by the time I finish, so that the assembling itself it will take 3 to 4 minutes. It's not the question of time in on table time. Basically, the thing is that the what type of post-operative or intraoperative trouble you are going to get if you are doing the combined case. Obviously, the cataract surgery with hydration and all those things, people become small and all those things are there. There are disadvantages. They are not there, then I don't think the patient will be more than happy to be wait for 10-15 minutes more in the theater.
More
Agreed.
importantly, I think even the rate of PVD induction and even the traction, if it is there pre-operatively, it will increase. If you just do the cataract surgery and wait for some time, the
Yeah.
tractions on the retina is going to increase. So
Yeah,
it is
no,
better that you go ahead and do the two things together, particularly if there is a tractional component. If there is tractional retinal detachment along with the vitreous hemorrhage, it is better that you go and do the two things together. If the cataract is not there or it's very minimal, I would, and if it is very uncontrolled, labile diabetes control, just for the sake of having a less trauma, I will defer it. Then I will just do the vitrectomy first and defer the cataract surgery for time being.
Manish, sir.
Manish, sir.
Yeah. So I think diabetic vitrectomy is a very gray area. You may, Dr. Mahesh Shanmugam used to tell us if you can see the retina in a diabetic, you are in trouble. But even in vitreous hemorrhage, what looks like vitreous hemorrhage where there is PVD present, you go inside and you may end up having a very bad TRD under the blood. So when I'm doing diabetic patients, usually diabetic patients also have their pupils are not really good. They may not hold throughout the combined procedure. That is one. Second, chances of epithelial edema are very high in these patients, especially if you have hydrated the side ports, and the chances of epithelial edema is high. On top of that, if you are having a bad retina underneath, sometimes the visualization can become very difficult. So in that, and we can't really assume that the vitrectomy is going to be very straightforward, especially in diabetic patients. So that is precisely the reason I like to I like to split the procedures rather than so when I've done cataract surgery first, I second a big advantage that I have found is in a week to 10 days time when I take up the patients for cataract surgery, the patient's capsule is much more stable. So when I'm doing the anterior vitrectomy, I can be much more bolder in doing anterior vitrectomy and doing even I do posterior capsulectomy in most of these patients where I'm very sure that I've removed the uh, the bridging traction in the anterior retina as well. So if you are doing it in combined procedure, the capsule may give way. The capsule may tear very uncontrollably. The IOL might become little more unstable. So these are the reasons actually I like to split these procedures, especially in diabetics. If it's a vein occlusion hemorrhage with cataract, I'm comfortable doing combined surgery. But if it's a bad diabetic uh, case where cataract is there, especially where there are a lot of corticocapsular adhesions, etc., I definitely split the procedure. So these are
My
2 points
missing.
of view.
If you're injecting gas, get cataract done because there's no second surgery. If you're injecting oil, do cataract later on because it gives me a chance to remove the perisilicon oil proliferation, to remove the ERM. Patients do better. Gas डालेंगे तो same sitting, oil डालेंगे तो anyway cataract later. So we always remove the ILM when we do an SOR. Almost always.
Even with a good macula.
एकदम ही परफेक्ट रहेगा तो नहीं, बट वो 2-3 महीने में थोड़ा बहुत हो ही जाता है. आई वुड से ऑलमोस्ट ऑल, आई लेट मी रिफ्रेश, अराउंड 40-50% ऑफ द टाइम्स थोड़ा भी ARM निकला, थोड़ा भी कुछ दिखा तो.
For
Maybe
this diabetic such eyes, why not remove the ILM at the time of primary vitrectomy only?
Why
That
not
saves
remove
it just removes the skin
that's
out
already
and
20 minutes down the surgery, whereas here in an SOR it's only 5 minutes down the surgery. So time वहां फिर बढ़ता है. SOR is just a, so removing an ILM after a tough diabetes is more table time, OT time, than when doing it in with SOR. Plus, I get rid of the perisilicon oil proliferation, all the pigments gives me
more
better.
this taut ILMs in these patients will also reduce the chance of postoperative chronic diabetic macular edema in these patients, because many of them will have some thickening of the macula. If you remove the
That is
ILM, the
taut
traction is
posterior
gone.
hyaloid phase. That is taut PHF, and that is removed most of the times.
But even this lot of when you do the PRP aggressively during the vitrectomy, and there is a chronic edema remaining after the vitrectomy also, if you get rid of the ILM in these patients, this edema will subside further. It helps
So
in
yes, if there's
even
gas, I would
removing the
remove it at the
traction.
same time. But if I'm injecting oil for that patient, it would be removed in the next surgery.
So
Peeling the
I
island in
like to
diabetic.
if I'm seeing very clear macula, then I won't do ILM peeling.
Yeah, then
Uh,
that's enough.
but if there is a lot of folds which are there, if there has been a traction, I like to do it because sometimes or a lot of times there is vitreoschisis, and
Yeah,
by doing ILM peeling, I'm very sure that I have removed the
Entire vitreous.
posterior
the
hyaloid
other end
phase.
could, yes.
Yeah, posterior hyaloid phase. So
Yeah.
I prefer to do ILM peeling in primary surgery.
So we have had a very fruitful discussion today. I thank Dr. Manish sir, Dr. Manoj sir for their insights, Dr. Bhushan sir and Dr. Ugle sir for fantastic presentations. Next, we would go on to vote of thanks, I feel.
It was a good discussion, almost 2 hours. After a long time, I am into the screen.
We have had.
Now we can start. Now we can start our retina surgery.
First sixer.
Chalo, thank you everyone.
Thank you, sir.
Great, Shubham, you have conducted very nice.
Over to Subodh Purohit, sir.
Yes, fantastic. Shubham has
On
conducted.
behalf of Vidarbha Ophthalmic Society, I would like to thank all the panelists, all the speakers, Dr. Manoj Sasode sir. Dr. Manoj Sasode sir must not be remembering me, but I was
I remember you.
Yes, I was at Pravara and I had a lecture from you at Jalna, and you had revised whole Kanski at that time. I still remember, and you are the same good teacher right now also, sir. We are really thankful to you for revisiting all the hemorrhages and other thing and giving us a wonderful wisdom of knowledge.
Good.
Then I would like to thank Dr. Manish Bapaye sir, Dr. Rajesh Ugle sir, Dr. Bhushan Uplanchwar, then Chairperson Dr. Anand Pangarkar sir for his wonderful insights, Dr. Deepak Nilawar sir for his valuable time, Dr. Shashank Banai sir, Shami Kambatkar, and moderators Dr. Sandeep Anjankar, Dr. Shubham Malpani, who has conducted very nicely and very pinpoint questions, which were all focused for the anterior segment surgeon along with the medical retina problems. Then Dr. Panelist, Dr. Shamik Mukadam, Dr. Ridhima Deshpande for her insightful knowledge, Dr. Himanshu Deshmukh, who always mixes his knowledge with the wit, Dr. Prashant Katre, Dr. Rahul Bahekar, Dr. Ayush Shangole, sir. Then I would like to thank the Chandrapur Ophthalmic Society President, Dr. Sandeep Mungantiwar, sir. And finally, I would like to thank our President and Chairman, Dr. Shon Chinchole, sir, and our Chairman Scientific Committee, Dr. Rahul Tiwari, for a wonderful presentation. Hope we will be conducting the same things every month. And thank you thank you all the audience. And at the last and not the least, I would like to thank Entor Pharma Company for sponsoring this and conducting so smoothly. Thank you very much. Thank you all. Have a nice
Thank you, everyone. Thank you, Sunil. Thank you so much for staying with us.
Thank you, everyone.